Hi, my name is Karen Flood. I'm one of the consultant obstetrician gynaecologists here in the Rotunda Hospital. I'm also a senior lecturer in RCSI, and I've been clinical lead of the recurrent pregnancy loss service in the Rotunda Hospital for the last 7 years. So recurrent miscarriage is strictly defined as 3 consecutive first trimester pregnancy losses or 2 consecutive second trimester losses. However, we have expanded that definition. Unfortunately, it happens in about 2 to 4% of couples, and normally 1 or 2 miscarriages may happen by chance alone, but we know when it becomes 3 miscarriages that this is outside the normal range, and this is the usual threshold we use for doing further investigations to see is there another cause. So in the Rotunda service, we accept referrals from the internal service, but also from GPs. As I said, we usually accept people who've had 3 miscarriages, but this includes people who've experienced ectopic pregnancies and biochemical losses, and they do not have to be consecutive. I also see people after the age of 38 if they've had 2 miscarriages, and ideally we try to triage or prioritise the people who've never achieved a successful pregnancy regardless of their age. So unfortunately there could be a lot of causes of recurrent miscarriage, and this is why it makes it quite difficult to evaluate. Also, there's always the element of chance in the background, but what we're trying to find is there something else contributing? Is there a clotting issue? Is there a hormonal issue? Is there something to do with the anatomy of the uterus? Or indeed, is there a genetic issue? Unfortunately though, we do find about 60% of couples never actually get a true cause for why the miscarriages they've experienced have happened. So when you come to the recurrent miscarriage clinic in the Rotunda, the initial steps are to perform a very thorough history. And we focus a lot on the pattern of miscarriages that somebody has experienced to see if this will guide us of the possible cause that's led to these losses. We also evaluate medical and surgical background, and then addressing all the different possible causes of miscarriage, then we broach the different investigations that will help us find out if these are within the normal range. So most times we provide support medications such as progesterone and aspirin. Obviously if there's a genetic cause, then there's more advanced testing and evaluation needs to be performed, and sometimes an operation might be needed if there's an issue with the anatomy of the uterus. But as I said earlier, a lot of times we don't find a definite cause, and it's more about providing support meds and early reassurance scans for the subsequent pregnancy. Well, certainly if somebody's experienced recurrent miscarriage, we would treat them as higher risk in the hospital setting. Within our service, we always see these patients in the first trimester for early reassurance scans. And this, I suppose, provides a lot of reassurance for these patients, but also makes sure that they're well looked after and seen as often as they need to be seen. Then later on in the pregnancy, we'll be very closely monitoring for things like preeclampsia and small babies, which are certainly a higher risk in women who've experienced recurrent miscarriage. I think hope is very, very important. I've led the service now for about 7 years, and I'm happy to say that the vast majority of patients, we see good outcomes. And this is really, really nice to see after having such a distressing time in their lives. Hope is so important. I don't think we talk about the positive outcomes that we see enough. And I certainly see my role as somebody who's positive and provides reassurance for these couples on their journey.